Then we'll cover how we can actually develop disease, peripheral artery disease specifically. Then we'll discover or work into quantifying the elastin microstructure of these arteries, how we would do that. Then the actual conclusions we can draw from our data, the correlations we can develop, as well as the applications. So first, let's look at the structure. Now, this artery is located right underneath the kneecap. It is a muscular artery, as being a peripheral artery, it should be. And we can see here, we have a stain image, Verhoeven-Gysen staining. And this stain image shows the general structure. You see a large central layer of smooth muscle cells, which give it that ability to actually flex while your limb is moving. And that's why, as you're sitting down right now, you can actually stand back up and your legs will not be sleepy anymore. You can revascularize. And an important component of the artery in that sense is actually this elastic lamina right here. This is the internal elastic lamina, and then the external elastic lamina. These two layers are what are responsible for allowing this limb or this artery to be able to resume its shape after kinking or after bending while you're sitting down or after you're walking. So it's extremely important in terms of revascularization and retention of its shape. And a very important note about elastin, though, is that it's been proven to run axially along this artery in terms of it runs up and down your leg, which helps it such that when you're growing, when you're aging, it stretches over time. So you have that axial pre-stretch, which allows it to flex and to resume its shape over time. Now, this artery is susceptible to disease and is infamous for peripheral artery disease. This is essentially when you have the kinking of this artery, and it allows for it to actually develop these plaques because you have a slower, more turbulent flow, and it leads to deposits of lipids as well as carbohydrates and calcium. Now we see here an actual disease artery. We see a very highly decreased internal volume or internal luminal cross-sectional area, and also the development of intimal hyperplasia, which is scar tissue that comes when you have this sort of lower flow, as well as calcium deposits down here. This is just to show that peripheral artery disease leads to all these different occlusions of the artery that can ultimately lead to ischemia as well as loss of a limb. And this is extremely negative for public health burden because even treatments of this sort of disease are usually, over 5-6 years, they actually, 50% of them don't work. You have a low patents here, as you would say. Now, we understand very well how the mechanisms work in terms of how this can be caused by mechanical stresses or by biological stimuli, but we're not too clear on how it can be caused on the micro scale. What are the correlations? And that's where my research came in. My research came in to basically say, how can we go from demographics like dyslipidemia or high levels of lipid in the blood, or from hypertension or from old age, and say, what is the elastin microstructure of the artery, and how can we better treat peripheral artery disease? So we want to develop a model that can do this, but to do that first we have to find a way to characterize elastin in images from patients. So what my goal is to actually develop this sort of program. So first, what we would do in my lab is we would take these arterial samples, which were taken from the Nebraska Organ Recovery System, and these are samples that stretch all the way from the hip to below the knee, and we would take them, we would dissect them, we'd take out this 13mm axial sample, and using also, this was IRB approved, so it allowed us to actually do this research. And we would stain it with Verhoeven-Gysen staining, which stains elastin black, stains smooth muscle cells and other tissues brown, as well as fibrous tissue red. Now we look at this elastic lamina right here, the black pixels, and we'd isolate them from the rest using a MATLAB algorithm. Furthermore, we'd take this image here, this black and white image, and we'd put it through some filters and some operators to get the actual lamina itself. We'd remove all the other sort of blips that were caused by nuclei that were stained as well. And in the end, what we would get would be thickness, density, and continuity of these arteries. And we did this for several arterial samples for over 100 patients. And in the end, what we got was a lot of data, a lot of interesting data that showed us, primarily here, that as one ages, the elastic lamina thickness decreases. So to go through this image stepwise, we see on the x-axis age in years, we see on the y-axis elastic lamina thickness, and this showed us a significant correlation that as you age, the thickness of your elastic lamina decreases. But what was even more interesting about this data was that it correlated with previous data that we collected. This is showing axial pre-stretch as a function of age. Again, age on the x-axis, axial pre-stretch on the y-axis. And we see here, for the same data sample, for the same set of data, we see the same negative trend, which makes sense, because if you think of the artery as a rubber band, and you stretch a rubber band for 20 years, and you look closely at that rubber band, you're not going to see as many extended particles, as many bands that are actually still intact. So it makes sense that over time you're going to lose the thickness of this layer. Furthermore, we subjected this model to more statistical analysis, multivariate analysis, to see how it functioned in terms of looking at body mass index, dyslipidemia, smoking, all these other risk factors. And we found that body mass index also correlates negatively with average thickness, as in higher body mass means lower thickness of your elastic lamina. Furthermore, we saw that elastic lamina continuity was correlated negatively with body mass. So as body mass increased, the number of breaks in your arterial elastic lamina decreased. Furthermore, we saw also a correlation between density and dyslipidemia. So if an individual was characterized as dyslipidemic, the density of their elastic lamina was much lower. And these were all statistically significant given our actual data analysis on our multivariate data output. We see here our standardized beta coefficients are all above 0.25 magnitude, which indicates correlation for all of these, including up here. This is our most significant, which I showed earlier, which is a negative 0.525 Pearson correlation coefficient. All of these are significant results, resulting from our putting this data into SPSS, which is a statistical analysis program. In the end, what can we do with all these equations? Now, we have all these equations that are statistically significant, and we can put them into a model to tell you if my patient is 50 years old, is dyslipidemic or hypertensive, or has all these different risk factors, what's his artery or her artery going to look like from the inside? So this is extremely important in terms of you can actually treat patients much more efficiently. You don't have to guess as to which sort of stent is more efficient or more effective for the purpose and can last longer. So this is ultimately for the goal of developing more patient-specific treatments of disease. And at the moment, we're actually working further on our model to get more statistical significance in our data, get more patient sample. And in the end, what we see here in conclusion, pulling everything back together, is that elastin degrades and changes as a function of age, body mass index, and dyslipidemia. Again, here we see our most major and important slides, as well as correlation that made a lot of sense and acted as validation. Furthermore, we see that we can analyze the microstructure of these arteries with MATLAB and different algorithms, and we can also say significantly that it's correlated with these different factors. Furthermore, we know for a fact that age, BMI, and dyslipidemia weren't the only factors that we tested. Like, we tested smoking and diabetes, and these didn't correlate. So that's another clue that these don't interact with elastin. It's almost a way to focus research more, so you know not to look for the specific correlations. And in the end, as I said, we do have to do more studies to confirm this research and also to get deeper into the mechanisms behind this. And in the end, it's never done, but it's all good. So in the end, I'd like to acknowledge the University of Nebraska Medical Center Department of Vascular Surgery, as well as their MD-PhD program, as well as the Meyerhoff Scholars Program for providing guidance in my preparation for this conference, and the Federation of American Societies for Experimental Biology travel grant, which brought me here today. I'd like to take any questions.
Questions? Yes, please. Use the microphone. Yeah.
Okay, well, we'll see it.
Yeah.
Is there any correlation with your research with like aneurysms? Because I know that aneurysms like widening the like.
Okay, that's a very good question. And the thing about these arteries is that these are muscular arteries, so they're not as susceptible to aneurysms, but it is common. We had 1 or 2 patients in our sample set of about 40 patients that we analyzed for this study that did have aneurysms. But it's not that much tied to elastin in this case. It's a multivariate process here because you have collagen, you have elastin, you have these different fibrous tissues and smooth muscle cells. In that case, it's likely from trauma as well as degradation of elastin. But what we see is that that actually happens mostly in the aorta, as you know, aortic aneurysms, because that elastin in the aorta has been proven to actually extend circumferentially. So it's not that much axially, it's more going in a circle, which actually helps the heart in its efficiency, so the aorta can expand. But if that elastin degrades over time, especially in elderly people, that's when you have the formation of aneurysms. Whereas in the femoral artery, it's all axial. It's not as prevalent. Thank you.
The degradation of the elastin, is it preventable at all?
That's actually one of the goals of this research in the end, to see if there's a way. At the moment, we're not sure. We're trying to, some other labs on the same floor and other mentors on the same floor are trying to isolate the proteins that are responsible for elastin degradation. But we're not yet sure exactly the mechanism behind it. We know that there are matrix metallopeptidases that are involved there. And then we also know that it's a multifaceted problem because it's not only elastin breakage. You also have, compounded with that, the formation of intimal hyperplasia, which is basically scar tissue on the inside of the artery. And in the end, it's definitely something that we're still working on. The problem is that this is a multifaceted system, as I've said multiple times. And it's difficult to go through and say that there's one thing that impacts only one other thing. So everything is cross-linked. But we're still trying.
And also you mentioned that there are treatments. Like what are those treatments entail, I guess?
So the primary treatment for this sort of disease, peripheral artery disease, is endovascular treatment, and that extends in 3 separate ways. One path you can go is just going through and doing a balloon angioplasty, which is the most common because it's the least invasive. You go in and you expand the plaque away, so you increase the luminal flow. But another method is actually, you can go in and put a stent, and there are 2 kinds of stents, which leads to the 3 in total. The first kind of stent is a self-expandable stent, and the second one is a balloon expandable stent. And the reason I say these 2 different methods is because in the self-expandable stent, you have no control of how far it goes. While in the balloon expandable, you know how far it's going to go because you're controlling it. And that's important, especially because if you know that your patient is dyslipidemic, or if your patient has specific risk factors and you know that their elastic lamina is a lot thinner, you can say, it's not a good idea to use a self-expandable stent because it'll probably burst the artery and lead to further treatment that needs to be done, more invasive treatment that could be more dangerous. So it's a very good question because you need, all these different treatments have to be balanced, and a good way to say it is that there are unknown unknowns sometimes, and this is trying to minimize those.
The first one is, what is your current academic status?
I'm a sophomore.
Graduate? No, undergrad.
Undergrad, yep.
And then the next question is, I know this hasn't been done before as well, but my question is, plate buildup, doesn't just occur through this femoral.
Yeah, femoral popliteal, yeah.
Yes, it occurs in other arteries as well. So, have you looked at maybe literature if this plate buildup is also due in other areas due to elastin degradation? It's not just, I guess, unique to this type of artery. And the second question is, I know that you mentioned that the correlation between age and then degradation of elastin, but on the outside as we age, skin sags. So there is also decrease of elastic protein there, and we know that most of the body is outside and age is inside too. So isn't that reasonable to believe that if outside we lose elasticity, then inside every part of our body we lose that as well? So why is that part of the disease not just part of the natural aging process?
Okay, so those are 2 very good questions. Now, the first question, in terms of the previous literature that has shown in other arteries, we know for a fact that the development of plaques is a hemodynamic process. It's due to lower luminal velocities, and these are very common in the femoral popliteal, basically because you have the bending of this artery all the time, and you have higher mechanical stresses because you're always walking. Most of the time you're walking in a day or you're sitting. So it's an area where you have a lot of these stresses that lead to degradation. So it's more the fact that here it happens mostly because you're moving it all the time. Whereas you can't have plaques that develop in the aorta because there's a split in the aorta. And that split is a location where you can have turbulent flow, as well as in the carotid artery, because you have the bulb of the carotid, which is, hemodynamically speaking, is one of the best places for plaque to build up because you have cyclones that form and it's lower luminal velocity as well. So it's not a factor of it just being where it is, it's more a factor of what it's subjected to each day in terms of the environment. And as for your second question, I skipped my mind at the second question. Could you repeat it? Sorry. Aging. Okay. The aging process. So we do know on the outside that elastin degrades. But the thing is that even though it does degrade on the outside, does not mean that it's not replenished on the inside sometimes. So elastin, we know, at least in the arteries, it's degraded, but it's never replenished. It's only made when before you're born and a few weeks afterwards. We're still actually working on the time scale. But that fact, the reason that we wanted to do this study in terms of elastin is because we wanted to get more data so we could actually analyze, well, what's happening? Like, what's the process? Because the environment of your arteries is different than the environment of your skin. And it's also the different layers of your artery. An interesting thing here is that it's not degrading because of internal luminal flow, as far as we can tell. It's not being pulled off, because this is the external elastic lamina. So, like as I can show here, this is the outside layer that we're studying, not the inside. So it's not degrading due to environment, per se. It seems to be just degrading due to all these stresses. And also, to look even closer, we can see here that there's elastin pieces down here in the fibrous tissue in the adventitia. And perhaps there's another study to say maybe it's not being pushed away, or it's not being solvated, it's not being dissolved, but rather it's being pulled out by the fibrous tissue. That's another idea. And we're not totally sure yet the mechanism.
Yeah, that's okay.
Gabrielle Canales, I'm with UMBC. So I had a question regarding what you were talking about before about it not having a correlation with diabetes.
Mm.
So you said it did have a correlation with obesity though, right?
Yes, BMI.
So with obesity, it's thinner, like less dense?
With obesity, it is thinner and it also has more breaks in it.
Okay. So wouldn't you expect to see some sort of correlation with like type 2 diabetes then?
Yes, well, we do expect, and that's the thing that we're trying to consolidate here. And one of the possible reasons that we didn't see that correlation is because it's not one-to-one. Not every person that has a high BMI has diabetes, so that's
Right.
one possibility. But also dyslipidemia is also related to diabetes, from what I know. And so that might actually be a facet there. But let me actually go to the slide where I showed this. So you're talking about these two images here. Now, we do want to do more studies on this. There is inherent uncertainty because of the fact that it's a human population, and the program itself is definitely, it does a lot of things automatically. So that's possibly a reason that we haven't seen it. And these correlations are not the strongest in the end, because this is negative 0.525, but compared to having something like 0.9, it's not strongest, and it's mainly because we're human and we vary so much in our anatomy. So.
Thank you.
Let's thank our